I offer you, can I offer you some tube to which will help you in peeing? Make lines very simple. Do not make it difficult. Just, Sarah, can we offer you a tube to put in the water bag which will help you in peeing? Or just putting a tube in water bag for helping in peeing. You can make your sentences as per your convenience, but that should be your after introduction, after agenda. Rather, I would say even before agenda. If I would have been in your place, I would have introduced myself. Hi, I'm Dr. Arora, one of the doctors posted in this thing. Or rather, in emergency situation, it should be more empathetic. How it would be more empathetic? Again, if it is a critical situation, if patient is coming with pain, retention of urine, bleeding, if excessive pain, excessive vomiting, any critical situation, you are not seeing the patient in your clinic or OPD, you are seeing the patient in labor ward, you are seeing the patient in emergency department, you are seeing the patient in postnatal ward, and you have been called by nurse or midwife for any critical situation. How should be your introduction? Hi, is it Sarah William? Yeah, doctor. Can I call you Sarah? Yeah, doctor. Sarah, will you confirm your age for me? Yeah, it's 32, doctor. Sarah, I'm Dr. Arora. I'm posted in postnatal ward. My midwife called me that you are not able to pass urine for past 3-4 hours. Yeah, doctor. Are you okay with that? If my nurse put, my midwife put a tube in your water bag, which will help you in peeing? Yes, doctor. You want some pain relief as well. It will be great, doctor. Just to confirm, any drug allergies? No, doctor. This should be your introduction. Empathy does not mean, oh my God, oh, so sorry, you're feeling so sad, oh, you're bad. No, this is an artificial empathy. And even examiner can judge that this is the word which you are putting from your brain, not from your heart. You have to involve your heart in your exam. And when you will involve your heart in your exam, it will come automatically. You will become empathetic automatically because you can see that, oh my God, she's not able to pass urine for 6 hours. Are you getting me? Am I making any sense to any of you?
Yes, ma'am.
Okay. So just be very, very, very empathetic, not by mouth, not by words, by your action. Your actions have to be empathetic. Your acts have to be empathetic. Talking empathetically, oh my God, so sorry, is not going to make any sense if you are not acting accordingly. She is dying with pain. She's not able to pass urine. Oh, sorry, not going to help her. But offering her tube, relieving her pain by making her pee is going to be more empathetic. This is my perception. So be empathetic, not only in your words, in your action as well. If you remember this line, there's no reason that you won't offer her immediate treatment. She has come with the excessive vomiting, and you are talking, may I know since when you're having this vomiting? Oh my God, how are you coping with it? You are sounding empathetic, but you are not acting empathetic. Being a doctor, you have to act empathetically more rather than sounding empathetic. So what would be your first step? I can see that you are vomiting since morning. Is it okay if I offer you some injection for controlling this vomiting? Yeah, just to confirm, any drug allergy. I minus will do the needful. Now, not only you're talking empathetically, you are acting also empathetically. So you are a safe doctor. Safe doctor does not mean that you are giving treatment, safe treatment. A safe doctor means who handle the immediate critical situation or condition immediately. That is also a safe doctor. Am I clear so far? So the first your action would be offering immediately something to her, then moving further. That I have gone through this task that you have, or I have gone through your notes that you have delivered your baby, this is it so? Yes. I would like to ask you a question to know more about you. Is it fine for you? Yes, doctor, because now she's relieved. The first HOPI should be, will you tell me more about your complaint? Do not say, will you tell me about your complaint? If you say, tell me about your complaint, again, she will start from A, B, C, D, E, F. You already know about from A to E. So choose your word wisely. because they have been instructed that way. If somebody asks this question, answer this way. If someone asks this question, answer this way. So your HOPI won't be tell me about your complaint. Your HOPI would be tell me more about your complaints. So more, she will add something in that. She will not say something which she has already uttered. Now, what all you should cover in postpartum voiding dysfunction? If she has not answered herself, then you have to make sure, when did your catheter or tube was removed? Are you able to feel your legs or move around? Are you eating, drinking well? Did you try to pass urine or did you go to washroom? Because in current talk, they have clearly mentioned that in prevention, there is one line that you have to encourage patient to walk to washroom to pass urine. So that should be your HOPI question, because that is one of the prevention of PPVD in talk. Did you go to washroom to pass urine? Whatever answer she gave, it's fine for you. Now you have your HOPI with you. This is should be the very first question of HOPI. Second rule, after asking about the presenting complaint, then you will go one by one about the delivery. Here I would like to mention one thing. Normally I suggest whatever question is related to that condition, if you can ask everything in HOPI, that will help you in completing your information gathering fast. How? I'll tell you. Divide your information gathering in two parts. First part, which is related to that task. Second part, which is a general information gathering. What happens when we try to mix that task with the general information gathering? It hampers your speed. It affects your speed. So now you complete your information gathering in 6 minutes. And then you think, why I was not able to complete? Reason being, when you want to add something of HOPI in medical condition, definitely you will think, then you will speak. It will hamper your speed. Divide your information gathering in two parts. First part is only about HOPI, and second part is general information gathering, which I'll let you know later on. So here first we'll talk, will you tell me more about your complaint? Then you will ask all 4-5 questions. Then second question your would be, did you face same complaint during pregnancy or before that as well? This should come in HOPI. So you will come to know about whether she has any such voiding dysfunction earlier as well. Third would be, you will talk about her delivery or recovery. So how are you doing now after delivery? Is there any breast pain? Pain in tummy, she has all three. There are 5 B's which you are supposed to address. First is the B for breastfeeding. So how's your breastfeeding? Did you start feeding Jack? Because she already mentioned the baby's name. If by chance she's not mentioning the baby's name, then before HOPI, to make a rapport with her, first you'll ask, may I know the name of your baby? How Jack is doing? Jack has started breastfeeding because it has passed 12 hours after delivery. Then you will start with your HOPI. But if she says about Jack, then do not ask this question. First ask about HOPI, then 5 B's in recovery. Have you started breastfeeding Jack? Second is bladder. She is already complaining of bladder. Third, have you opened your bowel? That is the next B. Fourth is the bleeding from the vagina. So how's your bleeding from down below? Fifth B is blood clot in legs and lungs. So are you feeling any kind of pain or swelling, especially on one leg? This is the recovery. You will always go retrospective. You will always go retrospective. Then after recovery, you will ask about the delivery, because you are going ulta. Delivery, will you tell me about your delivery? More about your delivery. More about your delivery. So whatever she has already explained you, she's not going to explain you again. What should be your main agenda? What you are supposed to ask if she is not covering? How did you deliver? Means any instrument has been used. What was the indication of instrument? Because it was a big baby. Third, was there any tear or any cut down below? None of you, neither Anam nor Saima has asked this question. This is such an important question because instrumental delivery is a risk factor for postpartum voiding dysfunction. Perineal tear, a risk factor for postpartum voiding dysfunction. So if you do not ask about risk factor, how would you come to a diagnosis? Will you tell me about your delivery, more about your delivery? How did you deliver? Why did they use instrument? Was there any cut given or any tear down below? Are you feeling any pain, swelling down below? This is about the delivery. Then very quickly about pregnancy. Can you tell me about your pregnancy, how it has been? Or it was all fine, doctor? Or yes, I have diabetes, or I had diabetes. If it is given in the task, then you simply say, that I can see that you have been diagnosed as diabetes. So are you taking your insulin on time? Yeah. So sugars are under control? Yeah. Did you have waterwork infection during your pregnancy? Because in a diabetic patient, having waterwork infection is very common. Waterwork infection again can be a risk factor for postpartum voiding dysfunction or urine retention. Then you will say, with your permission, because now you want to go through her delivery notes, now you want to go through her pregnancy notes. So rather than saying, first you will talk about the delivery notes, can I go through your delivery notes? Then you're talking about the pregnancy. Now you're saying, can I go through your pregnancy notes? Rather than recovery, delivery, pregnancy, now you say, Sarah, are you okay with it if I go through your pregnancy and the delivery notes? So you are saving your time. Next would be previous pregnancies. Is it your first pregnancy? If by any chance she has not mentioned, you ask straight away. Or if you mention in previous pregnancy, I did not have any problem, then will you tell me about your previous pregnancy? Yeah, I delivered Tom 4 years back. It was all right. Even at that point of time, I was having diabetes. May I know the weight, birth weight of the Tom? Yeah, that was around 3.6 kg. Thanks. Okay, got it. Never say okay. Got it. Right. This is how you have to acknowledge. Got it. Right. Correct. After that, now you have covered everything which is important for HOPI. Now blindly close your eyes and go with the information gathering. There is no need to ask last menstrual period here. There is no need to ask cervical cytology here. So you will skip gynecology history. Then next would be medical condition. Make a rule. If there is something like this, always rule out if there is any nerve condition. Anything where there is retention of urine, anything where there is overactive bladder, anything which is showing atonic bladder, make a rule, always rule out nerve condition. Just to confirm, any medical condition you see your GP for? No. Just to be specific, high blood sugar. If she has not mentioned any diabetes there, then high blood sugar, because this should be in your mind. If overactive bladder, could be high sugar, recurrent urine infection, right? So high blood sugar, any nerve condition. Are you taking any water tablets? Okay, that's fine. Then it is going to be routine surgery, plana, dimka, da, and till your blood group, whatever is your sequence. Here again, you are not supposed to ask blood group. You can ask about smoking because she might need catheterization. She might not be that mobile. So again, smoking, DVT is very, very important. So here we'll talk about DVT. Here we'll talk about smoking, but you can skip drugs, you can skip alcohol, you can skip blood group. Support at home is very, very important here. By any chance, if she says that I do not have enough support, do not wait that when I'll go to the second part of the task, then I'll offer her support. No, you are going to miss it 100%. Simply when she says, may I know whom do you live with? Oh, with my husband. May I know the name of your husband? John. So John is supportive to you. Do you have enough support at home to take care of you and your baby? Or Jack? No, doctor, I just have, we 3 or we 4 are there. Okay. In that case, I'll ask my senior midwife to arrange frequent meeting by health visitors and the midwife to take care of you and your baby. And we can arrange a lactation consultant as well, or lactation midwife as well, who will help you in latching your baby or latching Jack. So there are certain points which you have to address then and there. Do not wait for the second part of the task. Am I clear whatever I'm saying? Any volunteer now who wants to go for HOPI, 2 volunteer I want. One would play as a role player and one would play as a candidate. I won't volunteer, otherwise I won't go further. I want active participation. I don't want to waste your time and my time as well. If you're not learning as
Ma'am, can I do a...
Can I do? Is it Saima and is Aya and who else?
Can I do it, doctor?
Who is this? Bache, tell me your name, dear.
I'm Anna.
Okay. So, okay. So one would play what I do, Saima and Anam, right? First, I'll give you a chance. First, I'll give you a chance. One would play a role player and other would be the candidate. Do not take, because it's just about HOPI, it should not take more than 2 minutes. I will stop you once you cross 2 minutes. It is just 2 minutes you should take for HOPI.
Okay.
Prepare yourself and start. So it's Anam and Saima first, okay? Rest, everybody, please mute yourself.
So I will be patient, doctor. I will be role player.
You decide between two of you. But do it fast, dear.
Okay, Simon. Can I be a role player?
Okay, doctor. So I am a doctor.
Yeah.
Doctor, na? Okay.
Start.
Should I start?
Yes.
Doctor, the same scenario, but
same scenario. It's
same
absolutely
scenario.
same scenario.
Yes, same scenario. Okay. Hello, Sarah, how are you coping?
Yeah, doctor, I feel pain in my tummy, severe pain.
Okay, Sarah. So I gathered information from my nurse, and she told she told me you are unable to pass P.
Yeah.
So should I ask my nurse so she can pass rubber tube so it
Okay, doctor. Okay, no problem.
Do you have any kind of allergy?
No, nothing.
Okay. So Sarah, now you feel better?
Yeah.
Can I ask you a few questions?
Yes, doctor.
Okay, Sarah, when your catheter was removed?
Recording in progress.
Before, doctor?
Okay. So since 4 or 5 hours, you are unable to pass.
6 hours. I cannot pass urine. I tried. They told me to move around. So I move around and then I went to the toilet multiple times to pass urine. And I opened tap water. I put warm water on my private area, but still I cannot pass urine. I couldn't pass urine.
I understand your problem, Sarah. How are you eating and drinking well?
Yeah, it's well. I drank. Do it, but still I couldn't pass urine.
Okay, Sarah, do you have any problem previously? Same problem in during pregnancy?
Yeah. No, this is first. But doctor, I'm insulin since long times. Sometimes I get some UTI infection, urinary tract. I mean, some infection in my bladder sometimes.
Okay, Sarah. Sarah, you are telling me. So, are you taking any kind of the medication for this diabetes?
Yeah, I'm on an injection.
So, how is your diabetes? Is it controlled?
Yeah, it is well controlled.
Okay, sir. Do you are deliver a baby? Do you name your baby?
Yeah, Jack.
So how is Jack coping?
Yeah, he's okay. Yeah. Yeah.
Do you breastfeed?
Yes.
So Sarah, how you deliver?
I delivered with a spoon-like plate. They tried to deliver me because it was big baby and it was prolonged labor. And they were by that plate.
So any cut has been given down below?
Yeah. Yeah.
Do you feel any swelling on the down below area?
I feel discomfort in that area. Yeah, I feel a lot of discomfort.
You are feeling discomfort on that area. Okay. So, Sarah, if you allow me, can I go through your delivery notes and your
Yeah,
pregnancy
okay,
notes?
doctor.
Okay, thank you, Sarah. So, Sarah, could you tell me about your? Are you ever get pregnant before?
No, this is first pregnancy, doctor.
Okay, this is your first pregnancy. Okay, what you do? What are you? Any? You are follow your concern, especially you are telling me diabetes. Any other health
No,
concern?
nothing. Only that.
Any previous surgery on tummy and down
No,
below?
nothing.
Personal.
Yeah.
Do you smoke?
No, nothing.
Use alcohol or any recreational drugs? Hello.
Yeah. I'm hearing you.
So any recreational
No,
drugs?
nothing.
Okay. Did you start breastfeed your baby, Jack?
Yeah.
Okay. So any heavy bleeding?
No, nothing. Look, okay.
Okay. Do you know about your height weight ratio?
Yeah, 25.
Hmm. Any family history of the concern you want to discuss with
No,
me?
nothing. Nonsense.
Especially clot in the legs.
Nothing.
Okay. Do you feel depressed and down below, down in previously
No,
days?
fine, doctor.
Okay. Okay, thank you, Sarah. Can I examine you in front of the chaperone, if you allow me, Sarah?
Okay, yes.
Especially throughout
Saima,
your
that we'll
whole
discuss
as
later on. Saima, examination we'll
okay.
discuss later on. So, Saima,
Okay.
can I ask, are you regularly practicing? Have you taken any course? Are you working on it?
Yeah, ma'am,
I don't want to
I
know
have
which course
taken
you
a
are
course
taking. I'm
about
just asking. I don't want to know the name of the course. I'm just asking, are you practicing regularly? Saima, your
yeah,
second part of
but
information gathering has to be very fluent, which was not Saima. Which was not Saima.
mm,
You have to divide your information gathering here
okay.
in two parts, and second part you should finish in 1.5 minutes. Like how? Any medical concern
1.5.
for which you have to
Yeah.
see GP, especially like
Mm.
any high blood sugar, nerve condition. Do you take any water tablets? Just to confirm, any drug allergy or latex allergy? No. Any surgery in past on tummy or down below? No, doctor. Any family history of
Okay.
concern like blood clots, legs and lungs? I don't know, doctor. What do you do for living, Sarah? Okay. Whom do you live with? May I know his name? Okay. So George is supportive to you.
Mhm.
Are you enough supported at home for taking
Yeah.
care of you and your baby? Hmm. I got it. I'll ask my senior midwife to arrange frequent visits from
Mm.
health visitor and midwife for your health. And lactation midwife would also visit you to help latching check. Is it fine for you? Yeah. How your mood has been in past few weeks? I understand. Do you smoke?
Mm.
Uh, what's your weight to height ratio?
Okay.
That's it.
Mm.
Why you are asking recreational drug, darling? Saima,
Yes.
why? There's no need. It did
Mm.
not take even one minute. Now,
Okay.
whatever I've said, repeat in 1 minute. More than 1 minute,
Yes, ma'am.
I'll stop you. 1 minute. General information gathering, 1 minute. Start from the medical
Okay.
history. Fast.
Okay.
I want fast.
Okay.
Start.
Okay. Okay. So, do you have any health concern for that
Why,
follow your GP?
Saima, no. When you speak to your patient in your
Okay.
clinic, did you say this way? Did you talk to them this way? No. Then why are you saying here?
No, no,
This shows that you are not confident or you are not well prepared. I don't want any
not good.
no. Should be straight one line. Shoot.
Okay. So, Sarah, are you follow your GP for any health concern? Is raised blood sugar and raised blood pressure for any health concern?
No, doctor.
Do you have any surgery on the tummy and down below?
No, doctor.
Any health family history of the concern you want to discuss with me? Any drug allergy or any substance to allergy? Okay. How is support at your home? And what are you doing for your living? And your partner supportive? Okay. What's your height weight ratio? Do you smoke?
It was much, 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 much better. Now, everybody, please keep one pen and one pad with you. And whatever I'm saying, please note down. Second part of information gathering, make a sequence. First, obstetric history. Second, gynae history. In gynae history, A, menses, B, cervical cytology. Number 3, medical history. With medical history, remember medical, so drug comes together, right? Come together. So medical history followed by drug and latex allergy. Then surgical history, family history, occupational, or I call it as professional history. Then support history. Whom do you live with? May I know the name of your partner or husband? Is he supportive? These 3 questions are must. Asking husband name gives an impression that you are very, very empathetic doctor and you treat patient very friendly. Always ask partner's name, especially if it is husband. Always ask husband name. You should definitely ask. May I know his name? So John is supportive to you because once you come to know about his name, even in second part, when you would be needing the husband support, you won't say husband. You'll say, we'll discuss this with John as well. Achha, now I'm telling you, I'm just mentioning 2 sentences. This will discuss with your husband. This will discuss with John. Which one sounds more empathetic and friendly? You tell me, Saima.
John.
Yes, so simple.
So
So medical, so obstetric, gynae, medical, followed by drug, latex, surgical, family history, what you do for living, support at home, mental history. After that, smoking, alcohol, no need to signpost. It is clearly given in Lisa. Lisa is a book which is of college book. They have clearly mentioned there that no need to signpost for smoking and alcohol. Then, pardon me to ask any recreational drug. After that, simple, weight to height ratio and blood group. These 5 should come together. Smoking, alcohol, recreational drug, weight to height ratio and blood group. This sequence you should finish in 1 minute. So from now onwards, everyone, 3 times in a day, whenever you pray to your God, after your prayer, you will do this information gathering in your mind minimum 3 times every time. So 3 times in a day, and in every time you are going to do it 3 times in your mind after your prayer. Information gathering, second part of information gathering, you should be so fluent that you should finish in 1 minute. And trust me on that, Saima, Anam, Aya, Fareen, Farnaz, Fatima, if you practice it that way, there is no reason that you won't be able to finish. Saima, I have just given you example just now and you could able to finish in 1.5 minutes. So if you practice it daily, don't you tell me one thing. If I ask you about, tell me about Eid in 2 minutes, you will finish everything in 1.5 minutes. Am I wrong?
Yeah.
Okay. If I ask you to tell me about Deepavali, you will take half an hour because you are not accustomed with this festival. Whereas if I ask someone like Sanya, tell me about Deepavali, she'll tell me in 2 minutes. But if I ask her, tell me about Eid, she will take half an hour because she's not accustomed with that festival. It's so simple. So what I'm trying to say, if you are accustomed with certain thing, you will speak it very fast. If you are not accustomed with certain thing, you are going to take long time. So to be accustomed with that, what is the simple way to repeat it again and again and again? So everyone note down this sequence. And the second part of the information gathering should come from your spinal reflex, not from your brain. It should be that thorough. As you drive your car from your spinal reflex, as you swim from your spinal reflex, you do not use your brain because it comes out from your spinal reflex. With anything which is you are doing since years, you do it from your spinal reflex. You never use the brain because you don't need to. Anam, am I making any sense?
Yeah, yes, Dr.
My
Yes.
purpose of taking free session or Zoom session is not just to register my name in your logbook. Okay, Dr. Puuja is so and so. No, my purpose is that I'm investing my time, you're investing your time, so there should be some benefit to everyone. Clear? Anam, now I give you 3 minutes. You have to finish your information gathering fast. Then we'll move further. We have to discuss about.
Yeah.
Okay.
So, Sarah, how are you coping?
Where's the other girl? Saima, are you there? Saima, you play her role player now. And I want a very good presentation to move further.
Okay, ma'am.
Yeah, Sarah, how are you coping after your delivery?
Doctor, I'm not feeling well. I'm having very, I'm unable to pass P.
So, do you want any relief? Do you want me to give you some pain relief, or to put a small catheters inside your urethra to pass urine?
Yeah, doctor, please help me.
Do you feel now better than before?
Yes, doctor, I'm
Okay,
feeling.
Sarah. So, can you tell me more about your delivery? Exactly.
Yeah, doctor, my Jack is delivered half a day ago, and delivery was with a spoon, with help of the spoon, because of unable to bear down.
It was difficult delivery, or it was smoothly?
Yeah, it's a difficult delivery.
What about your baby weight?
So 4.5.
Okay. So do you have any pain down? Do you have any pain in your vagina, or is there any cut in your vagina?
I'm feeling discomfort, doctor.
Okay. Do you have any cut there?
Yes, doctor.
Simon, your voice is far, please.
Yes, doctor.
Okay, okay. So do you have any swelling or bulging there?
No, doctor, I didn't feel. I am unable to pass pee. Even doctor told me to move around and go to washroom, and I go to washroom but unable to pass pee.
Okay, yeah, Sarah.
So that's my main problem, my main
Okay.
concern.
Do you feel any sensation in your lower limb?
Yeah, doctor, I move around. I have a sensation past 3 hours.
Okay. Do you have any pain in your back? In the needle side?
Slightly, yeah, slightly pain.
Okay, Sarah, can you tell me more about your pregnancy?
Yes, doctor, this is my first pregnancy and this is my planned pregnancy. And me and my partner is very happy for the arrival of the Jack.
Okay. As I know, Sarah, from your note, you are diabetes. So how long in diabetes?
The doctor since past 5 years.
Okay. Is it well controlled?
Yeah, it's well controlled. I'm on insulin.
Okay. Only insulin?
Yeah, doctor, on insulin.
Do you have any other illness apart from diabetes? Are you on other medication apart from insulin?
No, doctor.
You
I
have any allergy? Have any allergy to latex or drugs medication?
No, doctor.
Okay.
No.
So what about your body mass index?
About 23.
Okay. Do you have any surgery?
Yeah, doctor, I had a surgery 3 years before for appendectomy. For appendix.
Okay. It was smooth. Was it smooth?
Yeah, doctor. It's for smooth.
Okay. So what about your blood group, Sarah?
Yes, doctor, it's A positive.
Okay. Are you up to date? Oh, second. So Sarah, with whom are you living?
Yeah, doctor, with my partner.
Is he supporting?
Yes, he's very supportive doctor.
Okay. What do you do for work? What do you do for a living?
Yes, doctor, I'm teacher.
Okay, so do you smoke?
Occasionally, doctor, and socially, I smoke a cigarette, one or two.
Okay. Do you drink, Sarah?
No, doctor.
I want to ask you, do you have the same problem previously like this in your water work? You have the same problem before?
Yes, doctor, I have. So I had multiple episodes of infection in my water bag. So I have taken multiple time treatment for that.
Okay. Okay, Sarah, thank you. Thank you for your
Okay.
time.
Thank you, doctor.
Okay. So it was okay, but definitely you all need little bit of practice. Okay. So am I clear now, Anna, how to prepare part 1 and part 2 of information gathering?
Yes, Tanya.
Okay. Anybody else has any confusion? Please come up with the confusion. So I'll just sort it right away. Girls? Or everybody is clear so I can move further.
Ma'am, when will you ask for the blood transfusion?
Here, see, when you think that patient may need any kind of surgery, then you will ask for the blood transfusion. For
Not in every patient.
postpartum, oh, sorry? Yes, Saima?
Not
Not in
not in every patient.
Of course not.
Okay.
In postpartum voiding dysfunction, what you are going to do with the blood transfusion? Nothing. Nothing. It is just wasting your time,
Okay.
right? Okay. Same with the
Mhm.
recreational drug. It is not going to make any sense. But definitely,
Okay.
for definitely asking depression history or mental history is very important, because if she has any such factor, or if she has postpartum psychosis or depression, then there is a possibility that because of this complication, she may again have the same problem. Getting my point? Because what are
Yes,
all
ma'am.
the risk factors for postpartum depression? Any traumatic delivery, any traumatic labor experience. Getting my point? So now, one more thing, Anam or Saima, I don't remember, but one of you mentioned nurse. Second very basic rule for all pregnancy, labor, delivery patient, we will mention midwife. For all gynae cases, we are going to mention nurse. Clear?
Okay, ma'am.
Okay. Mute yourself, Simon. Okay. So now this second part of the task, the between first and the second part of the task is the examination. In presence of chaperone, with your consent, these two are the patient safety point which you have to utter. In presence of chaperone, with your consent, if you do not utter these two words, you are compromising patient safety and patient communication both. One more suggestion. You think that there are 5 domains. I do not think that there are 5 domains. You cannot say someone that, okay, your patient safety was perfect, but your applied clinical knowledge was not perfect. If you see your result, if you failed in applied clinical knowledge, you must have failed in patient safety as well. If you have failed in patient safety, you must have failed applied clinical knowledge. Anyone who has given the exam before, just think about your result. That if you couldn't clear because of the any reason, you would see that. Only the information gathering is that which one may pass or fail in spite of passing or failing exam. But if you failed applied clinical knowledge, there is very less likely that you will pass patient safety, because you cannot segregate applied clinical knowledge, patient safety, or patient communication. Why? If you do not know the applied clinical knowledge or the treatment plan, you are going to give them wrong treatment plan. If you are going to give them wrong treatment plan, then you are going to compromise patient safety. As simple as that. So you cannot segregate all 5 domains, though information gathering is one thing which you can segregate definitely, but rest 4 The rest for that patient communication and safety, applied clinical knowledge and communication with colleague, these are robed within themselves. They are attached to themselves. A is with B, B with the C, C with the D. If you miss B, there are many chances or high chances that you will miss A or you will miss C as well, because you cannot segregate these four domains from each other. Second part of the task, in presence of the chaperone, I would like to do the examination with your consent. Now, two volunteers who will tell me examination and investigation for this task in 1.5 minutes. Two volunteer, please. If I will not get volunteer, I'll just stop my this session here itself.
Me, Dr. Ayo.
Yeah. What's your name? Can you pronounce your name, darling?
Aya.
So there's one Aya. Anybody else? Anyone else? Farnaz, Fatima, Guzal, Likita, Manikam, Nisreen, Pushpa, Shaheen, Shima, Shiraz, Hebaz.
Ma'am, you can make use of me if nobody is coming.
Manikam is definitely, I know she is so enthusiastic candidate. So Manikam, you are always standby for me. If no one would be there, I'll pick up you.
Monica, I will do for you.
Anyone else who want to try?
Can I do
Anyone?
it? If money can, if accepted, if money, can I do it?
It's
Yes, Anam, no problem.
I can do.
It's Farnaz, right? Yeah, so first, Aya, I give you 1.5 minutes. Please explain me examination and investigation. I just want relevant thing. Do not say anything just for the sake of saying. Take your 30 seconds to jot down and then shoot.
لحظة برجع لك ماشي.
Farnaz, mute yourself, darling.
I will start.
Aya, start.
Okay, Sarah, I would like to examine you in the presence of chaperone after your consent. I want to examine you generally, check your blood pressure and your pulse and temperature and your respiratory rate as well. Then I will examine your tummy to see if there is any swelling or tenderness. Then and I want to examine your from down below to check the tears, if there is any bleeding, or there is some swelling, and I arrange for you some blood tests. I will request for you full blood count, and I will request also your urine analysis, and I will arrange detect any infection, and also I will arrange ultrasound for you to check post residual volume after we insert you cassette to check the urine left there. And also I will order maybe I will need to order for you some MRI to check your if there is any problem with your epidural anesthesia. Is that okay with you?
Aya, I'll run away from the hospital if you'll advise me MRI. I'll literally run away. Do not jump to the bigger techniques, imaging techniques, or the test at the first go. I'll literally run away. I'll literally run away. Oh my God, I need to go for MRI because I've just delivered a baby and I've taken some injection at the back. Just tell me the relevant one. So for now, who was next? It was Farnaz, right? Farnaz?
Yes.
Yes. Now you have heard her, and then now it's your turn. And I want, because now you have already heard someone, so definitely you have to raise the bar. I was very good up to a certain point. Then in investigation, she indulged in, investigations which were not required, like full blood count. What was the significance of full blood count, Aya, here?
If she had any infection,
We are looking for
like
which infection, dear? We are looking for which infection, dear?
no.
Urine
No.
infection, right? So for urine
yes.
infection, you just need to do the urine dipstick. If there is any infection, then we'll go for the culture and we'll start the medicine to prevent
Yes.
infection. We call it as antibiotic. As simple as that. Mm, Another
Okay.
tip, make your presentation, make your template as simple, as simple, as simple as possible. Make it simplest template for yourself. Do not think uttering big words. Do not think mentioning big words, difficult English, twisted tongue is going to help you. No, it is not. Make your template as simple as that. Reason being, you are not going to present one task. You have to prepare almost 200 tasks. If you make it difficult, it would be difficult to retain. If you make it simple, if you make it logical, you do not need to memorize it. Am I making some sense, Aya? Do you find it like logical, whatever I'm saying?
Yes, definitely.
Yeah. If you make it simple, it is easy to retain. If you make it logical, it is more easy to retain. How logical? Urine retention. The first thing could be urine infection. So simple urine infection, I would advise. Second, I know that postpartum voiding dysfunction, once we empty the bladder, we always check the residual volume because that is the criteria for further treatment. Right?
Yes.
But
Yes.
now one more thing which I would like to mention here, that was the previous talk. In current talk, they check both the things. First, the amount which one has voided. That is the, has anybody gone through the current talk for that?
Yes, I have gone.
Who is this? Fanas? Who said this?
Yeah.
Shine? Who said this? Shine or Fanas? Fanas?
Farnas.
Yeah, Fanas. So can you tell me
Yes.
the algorithm? If patient is unable to void, so what is the algorithm for that?
Okay. If the patient is unable to void, in that we will ask, we measure the volume. And if the patient said she has voided, then ask the question, VASI questions. Okay. Which include volume.
No,
did
I'm
she feel
asking when
empty?
patient is unable to void. Our task is unable to void. So there in chart there are two, in the algorithm there are two charts. So I'm asking about the chart which is given on the right side. Unable to void. Then how do you proceed?
So, if she is unable the 4 hours, then again try for after 6 hours, and then pass the catheter and check the volume.
Volume
Depends
of
upon
what?
the volume. For the
Volume
management
of what? Residual
volume
volume or the urine passed?
urine volume.
Okay. Good.
Doctor, if we are checking the volume, patient is unable. That is the total volume. If we pass a catheter, then all the volume will come out. If the patient pass the urine and remaining urine, that is the residual. So in the patient who is not able to pass, that means that whole the volume is a total volume.
The volume she has passed, right? So what is the criteria? What is the criteria?
This patient is unable to pass urine.
Yes,
it means
I'm asking
she's
Farnaz.
retention.
No, I'm asking Farnaz. What is the criteria of amount of passed urine for further treatment?
Yeah, the criteria is that depend on the 3 levels. Less than 1, there is no need for the treatment. If she is passed between 150 and 250, then she needs to catheterize for the 24 hours. And if more than 700, then catheterize for the 2 weeks. That is the criteria.
You slightly mix first and the second. Is 150 to 250 if she pass urine, then you will ask her to void again after 6 hours.
Yeah.
If it is 250 to 700, basically remember that 150 to 250. Second is 250 to 700 and third is 700. Remember that way. 150
Okay,
to
okay.
250. Second is 250 to 700. Third is 700. So if it is 150 to 250, then we'll ask her again to pass urine after 6 hours or within 6 hours. If it is 250 to 700, then you will put for 1 day. Then after 1 day, you will try without catheter. But if it is more than 700, then it is for 2 weeks. So now everybody make a chart in your mind. It's 150 to 250, second 250 to 700, third 700. These are the three criteria. Okay? So this way you are going to decide about what should be your further plan of management. So this is when patient is unable to void. Second is when patient is able to void, but probably she is still feeling that she is having something inside. Then there is a second part that we'll definitely discuss. So now tell me about examination and investigation in 1.5 minutes.
I would like to, Sarah, I would like to examine you if you agree in the presence of chaperone, female chaperone, in the presence of my midwife.
No.
Okay.
You will say
So,
chaperone only. You will say chaperone only. Midwife for checking her vitals.
Okay. Okay. So again, Sarah, I would like to examine you if you agree in the presence of chaperone. And midwife will check your blood pressure, pulse, again weight and height ratio. Is it okay? And temperature. And then I will examine your tummy to feel if there is any palpable bladder, to see if there is any mass and tender points. And then from the down below to see your stitches, stitch line, and is there any swelling, redness, and I will ask you to cough, and then I will see if there is any leak. And I would like to do speculum examination, that is instrument pass to see if there is any lump. Is it okay?
Yeah, that's fine, doctor. But what is palpable bladder, doctor?
Means if your bladder is full and I can feel it in your tummy.
Okay. Okay.
So after examination, I would like to do some tests, Sarah.
Okay.
So first of all, after checking your allergy, I will pass a rubber tube catheter, and then collect the urine and check urine for any infection, to rule out any infections. Okay. And if there is any infection, we'll check what infection is it, which is called the culture sensitivity. Okay. And I will collect all the volume to see what is the volume of urine in your bladder. Okay. So then next time when you will pass urine, we might do an ultrasound to see what is the remaining amount of the urine in
No,
your
it's
bladder.
not required. It's not required for us. Again, that's the point which I wanted to mention here. Now, it was very nice up to a certain point, but again, I always say that please do not make it complicated. You were doing so good, then suddenly you made it complicated by talking something which was not required. Residual volume you mention when patient is able to void some urine. In this case, patient was not able to void urine at all. So that is the major difference between the algorithm which was given in the first talk and now in the second talk. There is major difference between these two. Okay, so now we'll talk how to go further. First thing, my midwife would check quickly for your blood pressure, temperature, pulse rate, and the breathing rate, and that's it. One line, 4-5 words, that's it. Midwife would check. I would quickly, in presence of chaperone, with your consent, check your tummy for any painful swelling just above the bikini line. That is palpable bladder. Painful swelling just above bikini line. And we'll check you from down below if there is any swelling or any pain in swelling, how your stitches, where there is any bleeding from down below, and quickly your leg for any painful swelling. You have to rule out DVT as well. It been 12 hours, probably she is not moving. You have to rule
Okay.
out DVT as well. Probably she is not moving. So you have to ask these certain questions quickly. Clear? So it is very simple. Now for the investigation, I would like to run some investigations as well to check the urine lipstick. If there is an infection, we may send the special test, culture sensitivity, and accordingly start the medicine. We call it as antibiotic. Ultrasound, a patient is not able to void, please do not mention here. Because in algorithm, it is clearly mentioned that there is no discussion, there is no mention of residual volume management or checking or assessing in the second part of the chart, where they are clearly given that unable to void urine. They have not mentioned it. So do not mix the chart. You have to go through this algorithm. That is what I'm saying. Now college has become smarter. Now they can pick up from any point of your chart. Right? So because she is not unable to void urine, it is clearly mentioned there is no need of measuring the residual volume. Here the criteria is now. So are you clear about information, this examination and investigation, everyone? Quickly say yes
Okay,
or no.
thank you.
Quickly say yes or no.
Yes, ma'am.
Yes. Okay. It's
Yes,
only
yes.
Manikam at the end who is attentive listener. Anyone else? I want to hear from two other girls.
Yes, yes.
Shaheen, oh, I
Yes,
could
yes.
hear your voice. Shaheen,
Yes.
very good. Oh, well, very good, very good. Well done. So now mute yourself. Okay, everyone. So now second part of the task, which is very, very important. In second part of the task, the very first thing, okay, now after combining your history and examination, I have come to a conclusion. We call it as postpartum voiding dysfunction. I can see that you are alone here. Do you want to call John? As I have to share lots of information. Do not say that some good news, bad news, or something like that, right? Because it could be just a urine infection as well. She can be all right with next voiding. So, would you like to call John? Because I have to share lots of information. Well, what is postpartum voiding dysfunction? When a woman is not able to pass urine spontaneously. Spontaneously is a very important buzzword. Within 6 hours of vaginal delivery or catheter removal. Everyone, please note down. This is how you are going to explain patient postpartum voiding dysfunction. When a patient or a mother or just delivered mother is not able to pass urine is spontaneously, a buzzword. Within 6 hours, another buzzword of vaginal delivery or catheter removal. Means if you have put catheter, then after removing catheter, you have to give her maximum 6 hour time. So this is how you are going to mention about the postpartum voiding dysfunction. Now next, we'll wait for all your investigation report. If there is any infection in urine, we'll start with some medication. We call it as antibiotic, which you have to take for certain days. If now you come to know, if your examiner says that, okay, she has passed only 150 ml or she has passed 150 to 250 ml, then you are going to talk according to the voided urine volume, which is 150 to 250, 250 to 700 and more than 700. If your examiner says she passed 150 to 250 ml, okay, Sarah, we'll wait for further 6 hours and we would suggest you to walk to the washroom to void your bladder or to void your water bag or to pee. Then we will decide about further plan of action. If your examiner says she could pass 250 to somewhere around 700 ml, or your examiner says that she passed 450 ml, so it is coming between 250 to 700. So Sarah, it is suggested to put a water pipe inside your, a tube in your water bag, which will help you in peeing. We'll keep it for 24 hours. After 24 hours, we'll remove it and we'll look for whether you are able to void spontaneously or not. Probably this will do in the morning time, somewhere around after 6 a.m. when all the hospital and all senior staff and the consultant would be there. How does it sound to you? If your examiner says that she voided almost 750 ml, then you are going to say, I'm afraid, Sarah, that we need to put a tube in your water bag for approximately 2 weeks. And you will be discharged with this tube inside your water bag. There will be a nurse would be assigned for you, will be in touch with you, who will guide you how to take care of your catheter. At any point of time, if you think that the tube is not draining urine or there is any blood, any foul smelling discharge, please report us immediately. It is suggested to eat and drink well and moving around, which you can do with the catheter. Do report us after 2 weeks. If you find any pain in tummy, fever, foul swelling discharge, excessive bleeding, these are our emergency contact number. It is suggested to continue with the feeding with Jack. You will not stop breastfeeding. Anything else which you want to ask? This time there was a new question. So everybody was shattered. Oh my God. Question was that now she has come after 2 weeks, catheter removed. Still she is having complaint of not able to pass urine or off and on retention. And most of the candidates were like, oh my God, what they have asked. Reason, they have prepared the recall, they have not prepared the topic. It is so clearly given in talk, so clearly that even after 2 weeks, you remove catheter and she comes with the complaint of off and on retention, you had to utter, they were supposed to utter only 4 lines. But they could not because of the fear, because they were not gone through the talk. It was only that when she came, you will talk about everything, then say, now you will be under the care of expert team of the doctor. A careful assessment is required, Sarah. You will be seen by a bladder doctor, we call it as urologist, and the nerve doctor as well. We would guide you about the putting catheter yourself. We call it as intermittent self-catheterization. This was the reply, and everybody was like, oh my God, what they have asked. Because now in this recall, they given you from the last step of the algorithm, where they have given that you will put this catheter for 2 weeks and you'll remove this catheter after 2 weeks. So they gave you recall that now patient has come after 2 weeks and now still he is having some problem with voiding. What will you do? It was so simple. So now I'll give you some idea about SPT. SD is very simple. Everybody, like if you go through talk, you would be able to do that. SPT, I'm giving you certain tips and tricks. What if this comes? What if that comes? Second question that patient may ask, why this has happened to me? So here you are going to mention about the risk factor. Who will tell me what are the risk factor for the postpartum voiding dysfunction? Volunteer, please.
I can.
Who is this?
Can I tell?
Shaheen? Yeah, Shaheen, because Shaheen has not.
Yeah.
Yes, Shaheen, you want to say something about it? You
Yeah,
know the risk
yeah.
factor? Yes. Tell me risk factors. If I ask you, doctor, why this has happened to me, what would be your reply?
Yes, Sarah. This can happen to any woman who is having prolonged labor, or can have by the spoon or the suction cup. Then it can happen, and sometimes due to the prolonged labor, and the risk of absorbing that the cut you have given down below, some nerve injury can happen, which can cause this dysfunction, and it can be healed itself over the time. So we will give you a trial of catheter for 2 weeks, and after 2 weeks we will assess you for that.
Perfect. Anyone else? I want 2 volunteer for every task, for every exercise. Fast, girls, fast. In half an hour, like I have just set this Zoom for half an hour, 2 hours. So it's already 1.5 hours. So we have half an hour only. I have to discuss so many things.
Was it okay?
It was perfect, Shine. It was absolutely perfect. But I want one more volunteer. So because if two girls will speak, everybody would able to, retain it. I want that today you learn postpartum voiding dysfunction. After that, whenever you present postpartum voiding dysfunction, you have to be perfect.
Thank you.
So anybody else?
Yes, ma'am. Can I?
Do, yeah. Yeah, please go ahead, Simon. But I want it very
Sarah?
proper, very proper.
Okay. Okay. So first of all, Sarah, basically there are the many causes of the postpartum voiding dysfunction. So first is that you had a delivery, which is a difficult delivery and a prolonged delivery, and there's an instrumental delivery we call the delivery with a spoon or cup, and cut is given down below. So these are, and also fear and anxiety because of the pain. You had a feeling of unable to pass urine. So in this condition, we can put a catheter on your water bag, and you can continue drain the catheter. You can drain the bladder through it, and after 24 hours, we can remove. So it depends on the 150, 250, 250, 700, and more than 700. So you can get 250 and 700. So we can put a catheter on
No,
your.
I was just asking about the risk factor. That's it, Saima. Great, well done. Okay. I would have added one more line in that, Saima. Sarah, it's difficult to pinpoint exact cause. Never say that you had this thing, you had this thing. She'll bounce back on you, doctor. Then why did not you do the cesarean? If I had so many complications, why did not you go for cesarean? Right? Because basically, if baby weight was 4.5 kg, patient was diabetic, we should offer her cesarean. Right? Saima, always make a rule. Everyone never say patient that you have done this, you have done that, that's why you have this problem. Simply say, Sarah, it's difficult to pinpoint exactly, but there are many risk factors which can cause this condition, like having that pain relief on your back, using spoon-like structure or instrument for delivering the baby, giving some cut down below or having tear down below. Is more common in the first delivery, and it is more common with when the duration of labor is very long. But Sarah, few women may have this condition in spite of not having any risk factor. This is clearly given in New Talk. A woman can also have postpartum voiding dysfunction even if she does not have any risk factor. So how can you say pinpointly that this has happened because of this? Am I making any sense, Saima, what I'm trying to say? Anam?
Yes, doctor, it's clear.
Yeah. So it's difficult to pinpoint, Sarah, what is the exact cause, but there are many certain risk factors which can cause this condition, like this. But few women, in spite of having no risk factor, can have the same condition. We are all there to support you. Now, so first you explain the diagnosis with mild BBN, definition, and the risk factor. Then next, how you are going to manage me, doctor. Then, if it has been given in your instruction that after voiding, patient has passed this much urine, accordingly, you will follow the algorithm. Whether it's 150 to 250, whether it's 250 to 750 or 700 or more than 700, the criteria is different for all three. Remember this 150 to 250, 250 to 700, more than 700. So if they say 800 ml, you should know. If they say 500 ml, you should know. If they say 200 ml, you should know what should be your next step. When patient is not able to void urine, residual volume assessment is not given in talk anymore. Clear? So this is about immediate. But what if patient comes after 2-3 weeks? So there will be two chart which you are going to follow. First, you are going to confirm whether she really has any kind of retention or this is just her fear because she has gone through it. So there will be two specific questions you are going to ask. First, you will talk about VESI, that is VESSI. When she will say this thing, that I am not able to pass urine for now. See, now the task is this. Now she is coming after 2 weeks. So now what will be your HOPI? Your HOPI is going to be VESSI. Are you getting me, girls? Your HOPI, when the patient is coming after 2 weeks removal of catheter, because now you have to confirm whether she really has postpartum voiding dysfunction or she is just feeling that way. So HOPI would be, did you pass a good volume of urine? That is first V for volume. Second is E. Did your bladder feel empty at the end? So E for empty. Then S. Do you have a sensation that you want to pass urine? That is S, sensation. Third, was your stream normal? That is fourth. Again another S. Was there any incontinence? Where means if you do not want to say incontinence, when you will say that, was there any leakage? So this is your HOPI. So this recall, this time it was little bit different. Here in HOPI, you can say, can you tell me more about your complaints? If she includes all these VESSI, then it's fine. If she does not, then you have to ask these 5 questions in HOPI. I repeat, VESSI. V for volume. Did you pass a good volume of urine? E for empty. Did your bladder feel empty at the end? S for sensation. Do you have sensation that you want to pass urine? Another S for stream. Was your stream normal? I for incontinence. Was there any leakage or incontinence? Who would like to repeat this HOPI for me fast? I have only 20 minutes remaining. Any volunteer other than these 3, 4? Monica?
Shall I, ma'am?
Yes, sure. Sure.
Sarah, do you feel is the volume of urine you have passed is adequate?
Very good.
Emptied after the passing urine. Do you have any sensation of fullness of the bladder? Do you have any if you are passing out your incontinence? One more, yes, ma'am.
Yes. Was your stream normal?
Was your stream normal? Thank you, ma'am.
Very good. One more volunteer. I want you all to remember postpartum voiding dysfunction now itself, so you do not need to go to talk again. Who will volunteer? What all 5 questions you are going to ask? Shaheen?
Dr. Shaheen. Yeah.
Shaheen, go ahead. It's VESSI. VESSI.
Sarah, so can you tell me how much urine you have passed, and do you feel that you have emptied your bladder?
Very good.
And do you feel that you want to pass more urine?
Perfect.
How was your stream?
Lovely.
And do you feel that you leak before or after the passing urine?
Just say, do you think that you leaked any time? Right, because there is no clear cut given it here that before or after passing. They have just mentioned, was there any incontinence? So just say, was there any leak?
Okay.
Perfect, Shine. It was very good. Well done. So girls, now I'm clear. Now I'm clear, girls. Here in this recall, what would be your algorithm now? Now your algorithm would be the second, the first. If VESSI suggests retention, yes or no? Because now she has come after 2 weeks and now you have gathered all the question. If VESSI comes positive, then she has that problem. If it comes negative, it means she does not have that problem. So how you are going to take it further? So here we are not going to talk about that 150, 250, 250, 700. That was immediately after delivery when she was not unable to pass urine. Here it is mentioned that she has voided. So it is given voided after 6 hours of delivery only. But this chart would go with that as well, because after 2 weeks, the patient was saying that it was not an acute retention. It was that sometimes he feels that there is some retention, she needs some time, or today she is not able to pass. So now here you're going to mention that whatever information she gives in VESSI, you are going to talk about the treatment plan in second part of the task, that is applied clinical knowledge. If her VESSI comes positive, then you are going to say that you will definitely offer the catheter in the beginning itself, because she has come with the acute retention that you have done in the beginning. Now you will say that we would offer you urine dipstick to check if there is any infection, and we will check the urine amount of urine remaining in the water bag. We call it as residual volume. Again, the criteria now remember is 250, 250 to 700 and 700. So do not mix it. That was 150 to 250, 250 to 700 and 700. Right? Here is the criteria 250, 250 to 700 and more than 700. So first one is different. Second is 250 to 700 and third is 700 in both the chart. But first one is less than 250 here, there it was 150 to 250. So if she says, okay, if she comes as positive in VESI and the residual volume is less than 250, you will just say that we will keep you for observation. Let's see if you are able to pass urine in next 6 hours. Then we will decide about further plan of action. If residual volume comes 250 to 700, then you will say that I am afraid that you need the catheterization, and simultaneously careful assessment, nerve doctor, urine doctor, and the last one was self-catheterization. Clear? That you will teach. But now I'm clear that recall can come anyways. It may come that immediately after delivery you have been called, it has been 6 hours, she is not able to pass urine, or now again one more thing, because they can give any kind of recall. Basically, criteria is not 6 hours, criteria is 4 hours. We will encourage women to void urine within 4 hours after catheter removal. If she is not able to pass, then you will give grace period of 2 hours further, that is 6 hours. So ideally it is 4 hours, not the 6 hours. 4 hours, then further 2 hours. If she is not able to, then it is going to be 6 hours. After 6 hours, if she is able to pass urine, again you have to do VESSI, because she couldn't pass within 4 hours. Girl, hear me clearly. If in exam they have given that you have been called, she was not able to pass urine, now you have been called and now you came to know that she had just passed her urine, you will not say that you are fine, go home. Remember that it is clearly given, if she is not able to pass 4 hours, then further 2 hours. So if she is passing exactly at 6 hours, you are not going to send her home just like that. Then you are going to ask again VESSI. Then if yes, if no. But if she is not able to pass urine, that algorithm we have already discussed. That is a very simple algorithm. Please go through it. Just remind or recall it again and again. Whatever level they give, you have to be smart enough to catch from that point and answering them. If unable to void urine less than 150 ml, if she voided urine, we have discussed 150, 200, 250, 700. There's one more column, that is if it is less than 150, then you have to consider causes of reduced urine output. Means you will look for other causes, like was there any excessive bleeding, whether she is anemic, is she dehydrated. These are the other causes which you have to rule out if she voids urine less than 150. I again repeat, 4 hours you will encourage, 2 hours great period. Then there are two charts, one if unable to void, one if able to void. If unable to void, then there are three criteria: 150 to 250, 250 to 700, and 700, which we have already discussed. Here there is one more criteria. If it is less than 150 ml, then you will rule out the other causes. Then it is going to be absolutely different recall. If it, because nowadays they are giving 3-4 pages. In one page they are giving the candidate instruction, and second page they are giving the instruction about the patient. Probably in one very small line they must have written somewhere that after 6 hours, after putting catheter, volume was around 110 ml. Then you are not going to go through this algorithm. You will immediately rule out was there with any bleeding, blood transfusion, any recent full blood count, whether she needs blood transfusion, whether she was adequately, there was a perfect perfusion, hypoperfusion, was there any inadequate liquid intake or IV fluid. You have to rule out all these conditions rather than going for that 150, 250 or 500. If it is less than 150, then it is not a postpartum voiding dysfunction. This is some systematic problem. There is some problem in her system. Probably she is not given adequate fluid, whether orally or IV. Probably she has bled a lot. Now she is anemic. She does not have enough blood volume. Am I clear so far? Am I clear so far? You have to, there are 2-3 pages they are giving. One is the candidate instruction where they are giving tasks and where they are giving that you will be assessed for the information gathering, blah, blah, blah. Then there is second page where they are giving the instruction about the delivery process, blood flow, blood volume, her hemoglobin, everything. There will be one single line which probably one can miss, where they might have mentioned that she passed urine 100 ml after putting the catheter. And forget about postpartum voiding dysfunction. You have to look for other. Clear? So this is how you are going to manage this. One more thing which she can ask: what if this happens again in next pregnancy? Then you will talk about the precautions or prevention which you are going to take in next pregnancy. So first you will talk about that it is way, no, one more thing. There's one more change in the talk. Earlier it was 4 to 6 hours encouraging the patient to pass urine. Now it is 3 hours during labor, that you have to encourage the patient to void every 3 hours. It is no more 4 to 6 hours. Please note down this line, that you have to encourage a patient to void urine every 3 hours. You have to avoid constipation. You have to give them appropriate pain relief, and you will advise patient to walk to the toilet much often. What all precautions you are going to tell her in next pregnancy? That first, providing adequate pain relief. Second, avoiding constipation. Third, walking to the washroom frequently or quite often. Third, you will encourage her now itself as well. If she says that, okay, I'm going back, you have removed my catheter, how will I do that? Or if you have been called after 4 hours, midwife has called you that now it has been 4 hours, doctor, I'm giving you all the scenario. Whatever it comes, how will you address that? Now midwife have called you that it has been 4 hours, doctor, we have removed catheter, she is not able to pass urine. So are you going to jump, okay, put a catheter and just drain out her urine? No. You will say, we will wait for 2 hours. It is suggested to go to washroom frequently. Please open all the taps in washroom. You can put your hand in cold water, or you can pour some cold water in your lower tummy as well. If you have been called before 6 hours, I'll say after removing the catheter, you can maximum wait for 6 hours. So you have been called at 4 hours. Do not jump directly to putting catheter. It's clearly given that you have to give grace period of 2 hours. In that 2 hours, you will guide Sarah, I would suggest you to go to walk or walking to washroom more often. Put your hand in cold water. You can open all the tap in washroom. Even you can pour some cold water in your lower tummy. This will help you in passing urine. Clear? Clear, girls? Yes. So these are certain measures you are going to tell the patient that you have to do this. In next pregnancy, we are going to take care of this. We'll avoid the constipation. We'll give the analgesia, and it is suggested to go to washroom more often. Walk yourself. This is very important. One more question which patient asks: am I going to have any long-term complication, or am I going to have any problem further? Here, if it is SD, then you are going to mention bladder distension, voiding dysfunction, lifelong catheterization, recurrent UTI, hydronephrosis, reducer muscle damage, nocturia, reducer underactivity. If you want to note down, please everyone note down. Long-term consequences, patient will also ask, and in SD, your examiner will also ask. Risk factor, your patient will also ask, your examiner will also ask. If your examiner asks, then you are going to tell voiding difficulties, diffuser damage and diffuser underactivities, increased frequency, nocturia, bladder distension, potentially lifelong catheterization, hydronephrosis, and kidney damage or renal damage. If patient asks, then you will say there is a risk of recurrent water infection, incomplete emptying of the water bag. You may feel dribbling after the passing urine. You may have a feeling of unemptying of water bag as well. Because in this recall, patient has asked this question. So if patient asks, you will answer this way. If your SD examiner asks, you will answer this way. What are the risk factor? What are the complication? How you are going to manage it? Your examiner will ask you, now patient has voided 250 ml, how you are going to manage it? Now patient has come after 2 weeks, again she is complaining, how you are going to manage it? So same you are going to tell in SD form. So you understood about the risk factor? You understood about the what all complication one can have? You understand how to prevent it? If patient is saying that she has waterwork infection, then in prevention, you will talk about urine analysis and the culture, adequate analgesia, avoid constipation, walking towards washroom quite frequently. If there is any perineal swelling and pain, then early catheterization. There should be a fluid intake and output chart during the labor, which should include oral and intravenous fluid and the urine voided. Again, prevention can be asked in SB separately. Please note down urine analysis and culture, adequate analgesia, avoid constipation, walking towards washroom, perineal swelling and pain, then the catheterization, then fluid intake and output chart, which will include oral and intravenous fluid and the urine voided. Patient should encourage every 3 hours to void urine during her labor. Very important. And very important, in her active phase of the labor, we have to either reduce the volume of indwelling catheter or we need to remove it. Otherwise, it will cause trauma to bladder. This is a very important patient safety point which you have to mention. Following delivery, if patient has perineal tear, if patient has epidural analgesia, you have to mention that we will offer catheterization unless pain is reduced, swelling is reduced, and patient is able to have sensation in her lower part of the body. That is a patient safety. If patient has delivered instrument, if patient has delivered under epidural, if there is swelling or pain down below, you have to offer catheterization. It is a safety point. These 3 points, epidural, instrumental, swelling down below, even if there is perineal tear, these 4 points you have to offer catheterization from your side. Always trial without catheter should do in the morning time when all the staff and seniors are there. Clear? Postpartum voiding dysfunction. Is it clear, everyone?
Ma'am, the
Yes.
Okay.
SD in SD.
Sorry?
Sorry, ma'am.
Yeah.
Ma'am,
Yeah.
Can you
Yeah.
repeat?
What do you want me to repeat here?
In structural discussion, the complication of the retention.
Voiding difficulties, yeah, voiding dysfunction, diffuser underactivity, diffuser damage and underactivity, increased frequency, nocturia, potentially lifelong catheterization, recurrent UTI, hydronephrosis, and renal damage. But in SPT, you are going to say recurrent waterwork infection, dribbling after peeing, feeling of incomplete emptying, there's difficulty in starting peeing, and kidney damage, and leakage as well. Leaking would be again a problem, that is overflow incontinence. So risk factors, complications, prevention, these are the 3-4 points which patient and your examiner both going to ask. There is one more thing your examiner may ask, just for your knowledge. There are 2 types of postpartum urinary retention. One is overt and one is covered. Overt, when inability to void spontaneously within 6 hours of vaginal delivery or after removal of catheter, even after cesarean section also. So within 6 hours of vaginal delivery or after removal of catheter within 6 hours. So this removal of catheter can happen even after cesarean. And covered, when post-voidal residual volume is 150 or more than that after spontaneous micturition. Probably your SD examiner can ask this question. May I know what are the types of postpartum urinary retention? So there are 2 types of postpartum urinary retention. One is overt. Overt, when clearly you can see that, okay, patient is not able to pass urine. It has been 6 hours after removing catheter or the delivery. This removing catheter is not only after epidural, instrumental, even after cesarean as well. Probably in next recall, they can give you as cesarean section. That means cesarean, now we have removed, now it has been 6 hours. So do not think that it is come something else. It is same postpartum voiding dysfunction. This time they have put catheter because of the cesarean. So this is overt because it is obviously you can see. So this is overt. Covered means which is not clearly obvious. Patient has voided urine, but the volume is 150 or more than that. That is the residual volume, not the voided volume. When the residual volume is 150 or more than that, after spontaneous peeing, it means it is covert PUR. So if your examiner asks, may I know the task, may I know the type of postpartum urinary retention? So there are 2 types of urinary retention. Otherwise, this factor I have told you, definition I have told you, and the complication I have told you, how to manage that chart I have told you, the current recall you would have said, or everybody should have said that now you will be under the expert team, nerve doctor, that is neurologist, bladder water bag doctor, that is the urologist, or the bladder doctor you can say, and there would be careful assessment of you and will teach you self catheterization. Nurse would be appointed for the same. This should be the reply, and in HOPI they should have included VESSI. This was the task, that if she comes after 2 weeks. And prevention, I have already told you what all prevention you have to take, because definitely is in perineal tear she asked, what if same thing happens in the future? So in postpartum voiding dysfunction, she is going to ask how you are going to take care in my next pregnancy. Am I going to have same complaint after delivery? Then you will say, no, we'll give you adequate pain relief. We'll avoid the constipation. We'll encourage to walk to washroom. We'll maintain a chart for input and output. We'll put the catheter for all these 4-5 reasons. We'll do the removal of catheter in the morning. Or this removal in the morning, you will say her now itself. If you say that, okay, her this voided urine is 450 ml, so we are putting a catheter, we'll put it for 24 hours. But see, if you have seen, it is 9 p.m. in the night, you have put a catheter, are you going to remove it next day, 24 hours at 9 p.m.? Who will answer this question?
No, doctor, usually we'll remove it early morning.
Very
So we
well
can
done. Very well done. Even if she's crossing 24 hours, we will not remove at 9 p.m. in the night. We'll remove it early morning. She may ask, they give you, okay, now it's 9 p.m., you are going there. So if you say, see, they catch you in a very small little things, which, see what happens. Everybody thinks they, oh, I have performed so well. I don't know why I couldn't pass. Probably you have missed this small tiny points. That time was given that it's 9 p.m. She has not passed urine. And now you went there and you have put a catheter and you have avoided the urine, and urine was 500 ml. So you quickly say, okay, we'll put a catheter and we'll remove it after 24 hours. And here you compromise patient safety. Here you will say that normally we put it for 24 hours, but 24 hours is going to be tomorrow night. So always it is suggested to remove in the early morning after 6 a.m. when all the staff and seniors are there. So rather than removing tomorrow night, we'll remove it day after tomorrow morning. Is it fine for you, Sarah? Anam, am I making any sense?
Yes, doctor. But I want to ask you a question. How long antibiotic if we put folic catheter for 2 weeks? How long we should continue antibiotic? Is it for
There is
for
no
5 to
clear cut.
7
There is
days?
no clear cut criteria of giving antibiotics, like, because normally in such cases we follow the hospital protocol. So if you do not, if somebody asks you this question, if patient asks you this question, then you will simply say, because in some cases we give for 5 days, in some cases we give for 7 days, in some hospital they give it for 2 weeks. If catheterization, there is a possible that urologist would say, no, we'll give it the antibiotic for 2 weeks, because this is a hospital protocol. So you will say, if there is any infection, we'll start the medication, we call it as antibiotic, and it would be given as per hospital protocol. Clear?
Okay, doctor. Okay.
As per hospital protocol. Simple. Finish then and there, because trust me on that, nobody is going to ask you, forget about mastitis, and there they have given clearly that 14 days. Nobody is going to ask you how long, because it depends upon consultant, it depends upon the hospital protocol rather. In NHS UK, it depends upon hospital protocol. What protocol they have decided for anything. Simply say as per hospital protocol, after ruling out your drug allergies. Clear?
Yes, ma'am.
So if postpartum voiding dysfunction comes at any point, at any level of algorithm, you should be able to address that. Diagnosis, BBN, definition of postpartum voiding dysfunction, what all risk factors, after the voiding volume or after the residual volume, depending upon whether you are going through the right side of chart or left side of the chart, you will tell the treatment plan. After that, always do not forget that she has delivered the baby. So it's not about only mentioning the postpartum voiding dysfunction. You will discuss about breastfeeding. You will discuss about the perineal care if she has had any perineal tear. Because the postpartum voiding dysfunction treatment is very short. And because she has delivered, you cannot miss this point, that it is suggested to continue with the breastfeeding. You will be given instruction about the perineal care. If she had perineal tear episiotomy, you have to mention that. It is suggested to avoid constipation, take good amount of liquid, take high fiber diet. And these are the red flag signs. If you find any such thing, Shazia, mute yourself. Shazia, it breaks my With my tablet. Okay. So I'm not able to see, these are certain charts. If you want to go through, please go through quickly. So it will be easy for you to remember. See, please mute yourself, everyone. Please mute yourself. Just go through this chart quickly so you would be able to remember most of it. Risk of the postpartum, previous incontinence. There's no wonder if in your exam they will give that this patient had postpartum voiding dysfunction in her previous delivery. Now she has come to you at 34 weeks of the pregnancy. She wanted to discuss her delivery options and she wanted to know how you are going to take care of her postpartum voiding dysfunction. Clear? There is a possibility because in perineal tear they give postnatal ward around. That was the first. Then after that they have given 2 weeks. Then they have given 6 weeks. Now probably now she is in her next pregnancy, 36 week, and she had tear in the previous pregnancy. Same can happen with this also, that she had this voiding dysfunction in previous pregnancy. Now she has come to you, discuss about the delivery plan for this time. Again, you are going to mention about the risk factor. Again, you are going to mention about the complication. But here you are going to mention since labor, that during labor we'll encourage you to pass urine every 3 hours. We'll give you adequate pain relief. We'll encourage you to walk to washroom. We'll avoid the constipation. If we need any instrumentation or epidural or swelling, we'll do the catheterization immediately. Then after 6 hours, we'll remove catheter and we'll again you to go to washroom to pass urine quite often. Within 4 hours, we'll advise you to put your hand in whole what and the opening the tap and this thing, whatever all measures which helps in the urination. These all you are going to mention there. We'll rule out the waterwork infection. We'll take care of your sugar levels. This is how we are going to take care of your postpartum voiding dysfunction in next pregnancy. If she has come to discuss her delivery options and she had this history in the previous pregnancy. Am I clear so far? I tried my level best to make it simple for all of you. Girls.
Thank you, ma'am. Excellent, ma'am.
You're too
Okay.
good.
So now who will tell me the last question, where you need catheterization or where you should offer catheterization? Fast.
Then
Fast. Whoever, just unmute because it will stop at any point of time. Where you will offer catheterization after delivery? Girls, fast.
If the patient
Not able. Please, Farnaz, continue.
if the
Patient-
patient is unable to pass urine and the urine volume is more than 700 ml.
I'm saying after delivery, what are the indications where you should offer catheterization immediately? That can be a question of examiner in STDR. Where you would offer
After
Yeah, when the epidural is
lovely
epidural is
and
when
when there is epidural, when there is instrument, right?
cesarean section.
When there is cesarean section, when there is perineal tear, when there is perineal swelling, when there is vulval hematoma. These are all the conditions where you immediately advise catheterization. I told you, no, that there are four.
and
There are four
postpartum
indications.
and postpartum hemorrhage.
That is a different thing because I don't think you can say that, because again postpartum hemorrhage can be a reason of decreased urine output, especially if it is less than 150, which we have already discussed. What
Yeah.
if they give that less than 150 ml? urine output, then you will forget about postpartum voiding dysfunction. You will go jump to that, whether there was any episiotomy which was bleeding, whether there any perineal tear which was bleeding, whether during cesarean she had excessive bleeding, whether she has any PPH, whether there was adequate oral intake when there was normal delivery, whether there was adequate intravenous fluid when it was cesarean section. If it was not that, then you will address that. Then it is going to be a different task. It is not going to be postpartum voiding. Whatever instruction they give details about the patient, not the candidate instruction I'm talking, where they give 3-4 line of tasks and you will be assessed on the information getting. I'm not talking about that. They give one more paper where they give all details that she delivered by forceps, baby weight is this, she has passed this much urine. Please go through that very fast and do not miss any line there, because just of the task in that instruction note which they are giving now, other than that candidate instruction. The game is all about that instruction page. Whoever is going through that page quickly and could able to retain it, that would be able to perform the task perfectly. Because if they have given 100 ml, if they have given 300 ml, if they have given 700 ml, the task is going to be absolutely different. In prevention, you have to mention the input-output charting. You have to mention the how many times she voided. Bladder emptying should be documented. One more very important line. Blood, you encourage 3-hourly, and bladder emptying during labor should be documented. Input-output charting, how many times she has taken oral, IV fluid, and how many times she has emptied the bladder. And earlier it was 4 hours, now they have made it 3 hours. And yes, one more thing which I forgot to mention. You have to go through the DUG chart as well. That is oxytocin. Why oxytocin? Anybody? Why it is important to check oxytocin, darlings?
Can lead to retention of fluid, ma'am.
Why?
Hyponatremia. Hyponatremia.
Oxytocin is an antidiuretic drug, isn't it?
Yes.
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 So where you are supposed to put catheter, because you are not able to remember, I am repeating it for you. Cesarean section, epidural, instrumental delivery, 3rd degree or more perineal tear, even manual removal of placenta. Even manual removal of placenta. So these are the indwelling catheter indication immediately after delivery or during delivery. This could be a question of your examiner. I repeat, cesarean section, epidural, instrumental delivery, and 3rd degree or more perineal tear, and manual removal of placenta. These are the 5 indications where you will immediately offer catheterization before she could lead or she could reach to the postpartum voiding dysfunction. Second important question is the risk factor, which we have already discussed so many times. Third is the what are the long-term complications. Fourth is the management. Management is that chart, which is very simple. Just go through it. And next question would be prevention. These 5 questions they may ask. 5 questions. That prevention. In prevention, constipation, repeatedly going the toilet and taking adequate analgesia, starting antibiotic, input-output charting, and emptying the bladder. That is the documentation of that. Any special drug like oxytocin. Probably she had PPH, right? She has been given oxytocin excessively, and then it acted as an antidiuretic, and that's why kidney is now in acute shutdown hoga na kidney ka. If there is excessive oxytocin, it is working as antidiuretic, there will be acute shutdown of kidney. What will you do then? You will simply give the fluid overload. You will do the fluid loading. Nothing else is required. You will give the fluid loading and you will give some diuretics. And you will involve the kidney specialist. If they say, they can write in your instruction letter that she was given 80 units of oxytocin because she was bleeding, though her hemoglobin is fine. She was transfused with blood, now her hemoglobin is 12. Then it is the oxytocin which acted as antidiuretic. Then you will simply involve kidney doctor and you may need some diuretics. Can anybody will tell me which diuretic normally we prefer in such cases?
Potassium aspirin.
Sorry? Okay, this is your homework. I'll wait for this and I'll see who answer it first. Whoever will answer it first, I'll give her a gift. A gift in form of chocolate or something that would be related to task, that would be related to your course or exam. Whoever will answer first.
Ma'am, please repeat, ma'am.
Question, should I repeat my question? If there is, we come to know that because of the overload of oxytocin, which is antidiuretic, this has happened. Antidiuretic or oxytocin was given because patient was bleeding. So ST5 instructed for oxytocin, and it been given almost 80 unit of oxytocin. Blood transfusion was done. Her blood is fine now. It's like 11 her hemoglobin, but still urine output is less, this much. Kidney function has been advised, and that is more or less normal. What will you do? You will involve kidney doctor, right? You may need the fluid in giving her fluid, IV fluid, and one medicine normally we suggest in such cases. What is that?
Prosemide.
Lovely. Very good. Well done. Well done. So this is just presence of mind. That's it. I am sure everyone is aware of this drug. I'm sure everyone is giving this drug in their daily practice. But it is just the pressure. You are not even able to remember which is like, you know, which you normally work from your spinal cord when you work in your hospital, when you manage a PPH. Everybody must be thinking, mind, oh my God, ye to mujhe bhi pata tha. Tell me, everybody is thinking that or not? Oh, I was knowing this thing. No?
Yes, ma'am.
Okay. Anything else, or should I finish it now? Or like, was it worth attending? Was it helpful for you? Now, are you able to face the postpartum voiding dysfunction, whether it comes as SPT, SD, or whatever level? Girls.
Definitely.
I have one question, doctor. You mentioned that when she went to the toilet, patient will open tap water. Is it cold water?
No. For tap water, it is the noise. It is the noise, right? When you open the tap of this, we do in our practice as well, no? We ask our nurse that open the tap of sink, of shower, of everything. This is the noise of water flow gives that sensation that you can pass urine.
Yeah, like reflex, involuntary.
Yeah, but dipping the hand in cold water, dipping your hand in cold water, soaking your hand in cold water will help. That is a different point, and that this is a different point. These are two different measures. Opening the tap in your washroom or dipping or soaking your hand in cold water, these are two different measures. Are you getting me, Anam?
Yeah, because I'm surprised that hand in cold water. Yeah, I get it. But we can put water also on her genitalia. It will be warm water.
Lower tummy, you can put slightly cold water. That will also help. That will also help. This is again a measure to help in voiding. A patient is not able to. We do not jump directly to catheter if it is less than 6 hours. Again, girls, please read the task properly. If they have mentioned that it has been 4 hours and midwife has called you, do not jump directly to putting the tube. In the beginning itself, first you will say, okay, here you can take the HOPI after offering some analgesic, then you can say, or if you want to be more systematic, you can say that I would suggest you to go and sit in the washroom. I'll ask my midwife to open all the taps, and meanwhile, you can dip your hand in your cold water. This will help you in voiding. Would you give trial? Would you like to give a trial for that? Probably this is something which you were supposed to mention in the treatment plan. An examiner will understand that you are aware of treatment plan, and you will gain the marks then and there in the beginning, because you know how to handle situation, how to handle patient, not how to handle task. You getting me? Okay, girls?
Yes, ma'am.
It's only Manikam who replies. No one else. Anam,
Yes, Doctor, clear. Thank you. It's really, it's a
Aya.
great session.
Aya, I will ask everyone's name.
Yes, yes, doctor. Thank you so much for your valuable informations.
Farnaz,
Okay.
Fatima,
Thank you.
Fatima. Fatima is sleeping. Likita. Likita is okay. Okay. Manikam,
Excellent.
Shaheen. Very good. Shaheen,
Thank you very much, Dr.
is it clear
A
to you
very
now?
nice session. Yeah.
Okay.
Yeah.
Shima, Shima.
I could just memorize it also.
Okay. Shima is not there. Hebaz. Hebaz is also, I don't know where. So I'm just winding up now, and that's all for today. I'll try to come up with any other tasks or any other topic. Rather, I don't call it task. I never go for routine Zoom session. Like I will ask anyone to present 10 minutes task, because I think that you do in many free session, many Zoom session in your regular course as well. I just want you to guide about the topic. I don't want you to be expert in a recall. I want you to be expert in a topic. So anything comes from that particular topic, you have to have that expertise that you can face that recall. That is my principle of doing Zoom session. So I do not go for the conventional Zoom session and asking anyone to present task for 10 minutes. I hope this is fine for all of you.
Yes, ma'am.
Yes, Doctor.
Okay, good
Yes.
night. Good night, good night, good night, everyone.
Night.
you.
Good night.
Thanks for attending my this session. In spite I've changed the timing because there was one delivery, so I got delayed there. So I'm so very thankful. In spite of that, with such a short notice, everybody could make it. So be very, very, very focused, God darlings. It is a very simple exam. If you are well prepared, it is a very difficult exam if you are not very well prepared. So just do not take it for granted. Still, you have 2.5 months. It is going to be online, and so remote exams are definitely have many, many advantages in regards to stations or the tasks. So please. At least try, at least practice 2 tasks daily. That is a must. That whatever is the situation, 2 tasks you have to practice daily. It is a very, very, very important for everyone. Good night, goodbye, take care, love you, darlings.